So the first thing is this thing here. There's, up till now, and currently there is no ICD classification of chronic pain, which makes it difficult in terms of coding. It makes it difficult in terms of getting governments and funders getting an idea of the size of the problem. But currently before the World Health Organization is an ICD-11, which for the first time will have a classification of chronic pain. Now notice the term there is chronic rather than persistent. So the new term will be chronic, or not new term, going back, the old term will be chronic pain. So chronic pain itself is defined as persistent or recurrent pain lasting longer than 3 months. But there's 7 categories in the proposed new classification of chronic pain. And the first one I want to draw your particular attention to is chronic primary pain. Okay, now this is really important, and it's going to ruffle a lot of feathers, and some people are going to have difficulty getting their heads around it, because what it's talking about is, up till now we're familiar with chronic pain, primary pain above the neck. We call that primary headaches. But for some reason, chronic pain was never thought to affect people below the neck. But of course it does, and anyone who sees patients and listens to patients realises that, but it's never been recognised till now. So chronic primary pain will include pain below the neck as well. And it's defined as one or more anatomic regions that persists or occurs longer than 3 months and is associated with significant emotional distress or significant functional disability, interfering with activities of daily life. Okay, so let's just focus on that for a second. You know, it's not just the minor aches and pains of daily life. We're not medicalising the aches and pains of daily life. We're saying this is chronic pain it's in a different realm than that. It's actually disabling and it's distressing. Yeah? That's required to meet the criteria of chronic primary pain, and can be better explained by another chronic pain condition. And there's 2 subcategories of that: widespread chronic pain, including fibromyalgia. So the first thing, people who've got an allergy to the term fibromyalgia are going to have to get over it. It's going to be the new ICD-11. Okay, fibromyalgia is no longer a disputed diagnosis. It's a condition. And then the next thing is localized chronic primary pain. And the examples given are non-specific back pain and chronic pelvic pain. Now this is really important, because what we're saying here, back pain may not be a sign of a problem in your back. It may be a sign of a problem with your nociceptive system. Therefore, more investigations and more treatments aimed at peripheral tissues may not be effective. So, localized musculoskeletal pain, similarly chronic pelvic pain, may not be a sign of well-hidden endometriosis. It may be that there is no endometriosis. It may be that the chronic pelvic pain is a manifestation of chronic primary pain, rather than a sign of occult endometriosis or other pelvic pathology. So people have to get their heads around this, that this is chronic primary pain is a condition. Now these are the other 6 categories here: cancer pain, treatment of the cancer like post-surgical, post-radiotherapy, post-chemotherapy, chronic post-surgical and post-traumatic pain, neuropathic pain, headache and orofacial pain, and then the last 2 are where the chronic pain is actually due to peripheral causes, visceral pain or musculoskeletal pain. For example, the person languishing on the waiting list for their OA hip, the pain goes when they've got their hip replacement. It's chronic musculoskeletal pain due to peripheral cause. Okay, so these are the categories that will be in the new ICD-11. Okay, so nociplastic pain is a term that was introduced by the International Association for the Study of Pain just last December, and it's to describe the mechanism of pain that with clinical and psychophysical findings that suggest altered nociception. So it comes from nociceptive plasticity, nociplastic pain. So the idea is that this is pain that's neither due to peripheral pathology or stimulation of peripheral nociceptors, like you stub your toe, your foot goes into a hot bath, whatever. So it's not nociceptive pain, but neither is it neuropathic pain. Neuropathic pain is defined strictly as pain arising from a disease or lesion of the somatosensory nervous system. So you have to satisfy a neurologist that there's a lesion of a nerve before you can diagnose neuropathic pain. So the word neuropathic pain is often used loosely and inaccurately. Okay. Now, a patient can have a combination of nociceptive and nociplastic pain, and particularly problematic people, is people we know who have ischemic heart disease, but also have non-cardiac chest pain. And is their chest pain a manifestation of ischemia, or is it a manifestation of a chronic primary pain disorder? Okay, so that's the mechanism underlying chronic pain. Now, every year, the Lancet publishes the results of the Global Burden of Diseases study. The most recent one was on the 16th of September 2017, 400-odd page edition of the Lancet that month. It's funded by the Bill and Melinda Gates Foundation, huge study, hugely expensive. Now, the 2017 paper included to the end of 2016, and the conclusion was that globally, low back pain, migraine, age-related and other hearing loss, such as I've got, and iron deficiency anemia and major depressive disorder were the 5 leading causes of years lived with disability in 2016. Now in red are the 2 chronic pain conditions, and in green is the associated psychological problem. So, chronic pain is the leading cause of disability globally. It's not a small problem, it's a major problem. So these are the top 9 causes globally. In red, the chronic pain conditions. So 4 of the leading 7 causes of disability globally are chronic pain conditions. And in green are the associated psychological conditions that often go along with chronic pain. So this is a major disease burden and disability. Now this is a map from the same paper, shows the leading cause of disability country by country. The areas in purple are the parts of the world where low back pain is the leading cause of disability. This is for males. So you can see it's not just a problem of the first world, it's a problem of Africa, of South America, of Asia. This is males, oopsie, sorry. Those areas up there are opioid use disorders, those colours there. That's hearing loss in China. That is HIV/AIDS. So that's males. This is females. Much the same, purple, low back pain, still Australia and New Zealand, leading cause of disability is low back pain in females. Again, HIV/AIDS. But you can see the size of the issue that we've got here. Okay, so the same study has figures for each of the 193 countries that they surveyed. So in New Zealand's figures in 2016, these are leading cause of disability. So 4 of the 6 leading causes of disability are chronic pain conditions, and 2 of them are the associated psychological problems. So when you look at this, several things emerge. First of all, chronic pain is a huge problem globally and in New Zealand. Secondly, this is not a soluble problem. If it was a soluble problem, they wouldn't be the leading cause of disability. Okay? So you're going to come across it and you're not going to be able to fix it. Okay? Really important points. Okay, so 1 in 5 New Zealanders have persistent or chronic pain. They live with chronic pain. There's figures from the Ministry of Health 2016. Now, okay, so that's the size of the problem. So the complexity of pain. So this is Descartes' model from the 17th century. Simplistic notion: foot near a hot fire causes stimulation, and animal spirits activate areas in the brain, and you feel pain. So this is what we thought we knew about pain. Pain was always a result of damage, injury or illness. The worse the damage, the worse the pain. There's a single pain centre in the brain, and where you feel the pain is where the problem is. So that's a sort of naive, simplistic view of pain. And it does apply in some forms of pain. Stub your toe, it is accurate. You did stub your right big toe, that's where the pain is, that's where the problem is. It is accurate, okay? But there's more to it than that. Okay, but there's evidence to show it's more complex than that. So this is a case that was reported in the BMJ in 1995. This was a builder. Building site, got a nail through his steel cap boot, emerged on the upside of his steel cap. He attended the Royal Leicester Infirmary, and he had severe pain with a nail through his boot. So he had IV midazolam and fentanyl. And under the influence of that, they pulled the nail out from his boot, and then they took his boot off. When the boot was removed, the nail had passed cleanly between two toes. He didn't even have a scratch. There was not even a scratch on his toe. So he's not a wimp, he's a builder, you know, he works physically hard, you know. But he did have a sensation. He had several sensations. He had a hard, cold nail pushing up between his toes. And every time he moved his foot, that nail pushed into his tissues. He also had sensory input from his eyes. He could see this nail coming up there. So sensory input suggested it didn't, but out of that the brain made pain. It came up with pain, even though there was no tissue damage. Pain with no injury. Then the next case is opposite. Another builder, another nail, another country. Builder developed toothache over a number of days. He went to a dentist. So there you are. There's the nail. He hadn't known that he'd shot himself in the face with a nail gun. He was aware of vague pain in his face. So here's a case of he was unaware of the injury. So it didn't have the same cognitive and effective emotional impact. So there was some nociception going on, but it was downplayed because it didn't have the contextual significance. So injury with no or little pain. Okay, and this is a guy, woman.
Yeah, so this is, we use this in our patient education talks. Bethany was in a little bay in Hawaii, and you know there's a movie and a book, so most people are aware of it. And they were messing around on their boards, waiting for a set of waves to come through, apparently mimicking porpoises, which is not a good idea. And Great White probably bit her arm off and the board. But the take-home message was that her reported experience was that A, she was unaware that she'd actually been bitten. B, she had no pain. The need for survival drove her to the shore, and her father was there, and they went to the local hospital. There happened to be a surgeon there that day, and she was saved. So really, just a really good example of pain overridden by the need to survive.
Tissue damage and no pain. Yeah. Okay. So next idea is that pain's not always proportional to the size of the injury. Now we've seen that in the last few slides, but this one again, a paper cut can be quite painful. Minimal trivial injury. Pain with no body part, phantom pain, phantom limb pain. But we've seen people with phantom visceral pain. They've had an organ taken out and they've got the same pain present. And if we get time later, I'll give you some really interesting examples of that. But so phantom visceral pain. Pain felt in a site other than where the problem is. So myocardial ischemia may be felt in the arm or the chin. Ice cream headache. Cold stimulation of the pharynx causes pain in the head and his hair to stand up on end. Pain when the problem is fixed, endometriosis, and you've all seen this, and our skit this morning touched on this sort of problem. Pelvic pain. So we have a gynaecologist who's currently our pain fellow, trying to be a pain specialist. So she's educating us about endometriosis. This is the slide she put. That's apparently some staging mechanism, staging of endometriosis, I gather. But anyway, she tells us there's no significant correlation between the stage of endometriosis and the amount of pain experienced. No correlation, okay? Secondly, negative laparoscopic findings occur in up to 40% of patients with chronic pelvic pain. Doesn't mean the endometriosis is hiding. It means that there is actually no endometriosis. And in 1 to 43% of asymptomatic women who undergo tubal ligation or are investigated for infertility. And you say, what the hell is this person? And you do a laparoscopy and their pelvis is full of endometriosis, but they've never had pelvic pain. Okay, so pain when the problem has been fixed, nice surgical fusion. Pain when all the tests are normal, such as fibromyalgia, all the tests come back normal. So what's wrong? Pain, so again, the lack of relationship between pathology visible on imaging and symptoms. So disc bulge, disc prolapse with no back pain, and beautiful MRI spine with back pain. So this was published in the American Journal of Neuroradiology 2014. 50-year-olds who have no low back pain, 80% of them have disc degeneration. Okay, this is highly significant. So if someone's got back pain and you do an MRI scan, they've got disc degeneration, you cannot conclude, therefore, that the disc degeneration is causing their back pain, but people will do that. I was at a conference last week in Sydney where neurosurgeon was talking about black disc disease. Load of bollocks, okay? 80% of people who are asymptomatic have disc degeneration. It's not black disc disease, it's called, just like I don't have grey hair disease. I have grey hair, it's a normal effect of ageing, okay? Disc bulge present in 60% of 50-year-olds with no back pain, and disc prolapse in 36% of adults, 50-year-olds with no back pain. Okay? The lack of relationship between operative or imaging findings and pain. This was published the next year in the American Journal of Neuroradiology, 2015. The sort of green colours are 20-year-olds, the blue colours are 80-year-olds. These are all asymptomatic. They have no low back pain. So disc degeneration is present in 37% of asymptomatic 20-year-olds and is present in 96% of asymptomatic 80-year-olds, right down to disc protrusion, present in 29%, 29% of asymptomatic 20-year-olds and 43% of asymptomatic 80-year-olds. So degenerative changes and disc changes are common in asymptomatic people. Therefore, it does not follow that what you see in the imaging is the cause of the problem. Therefore, it follows that if you fix it by fusing the disc, you will not necessarily fix the pain problem.
Is that probably a good argument for not taking a picture in the first place?
Yes, it is. It is.
We're going to come to that today.
People have back 21 years ago, 1997, the Lancet had a systematic review of imaging, plain X-ray imaging of low back pain, and the editorial comment in 1997 was that we need to change the way we report radiological findings. We should stop calling these. We need to even stop commenting on them.